Welcome, everyone. I'm Dick Deming, Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic tonight is genetic testing and genetic counseling, and our guest is an expert in this, Elizabeth McDonald Blume, the genetic counselor at the MercyOne Richard Deming Cancer Center. Welcome, Elizabeth.
Thank you for having me back.
Yeah, it's great to have you. A very important topic that's becoming even more important the more we learn about genetics. So we're going to talk all about genetics, genetic testing, genetic counseling. We'll talk a little bit about genomics as well, just to cover the whole spectrum. But before we do that, refresh our memory. Tell us a little bit about yourself. Where did you grow up?
I grew up in Webster City, Iowa, central Iowa. It's about 20 miles east of Fort Dodge.
And then where'd you go to college?
I went to college at Buena Vista University in Storm Lake.
When did genetic counseling kind of come on your radar screen as a profession?
Honestly, it probably didn't really come along till well after I had my undergraduate degree. I had known about it at the time, but I don't know if I had really considered it all that much. It wasn't until I was working in the Iowa Newborn Screening Program where I got to actually work with genetic counselors.
What was your undergraduate degree?
Biology and psychology.
Okay.
So
and then the program that you were working in was
the Iowa Newborn Screening Program. So I was a laboratory personnel for 13 years there.
Oh.
Yeah. And so I had the opportunity to work with a genetic counselor closely as I was doing a lot of testing for hemoglobinopathies, which we know are genetic conditions.
Mm-hmm.
And I just really kind of fell in love with what she did and decided I wanted to take a stab at it myself. So
right. I'd forgotten that you had a 13-year career in the laboratory. And then what was it like to go back for training? What is training for becoming a genetic counselor?
Going back to school, I had always been warned, hey, it's going to be a little rough after you've been out of there for a while, and that is probably true. But I was really excited, and when I did get the news that I had been accepted into the University of Nebraska Medical Center program, it was great. The training consists of a 2-year program, 5 semesters straight. The first semester is largely didactic training and classwork, and the rest of it incorporates more and more clinical time as well. And so the training spans a wide variety of disciplines, but primarily oncology, prenatal genetic counseling, and adult and general genetics, pediatric genetics are kind of the big 3 areas.
Okay. And you finished your training in 2023. 23.
Yep.
And have been with us since then.
Yes.
Yes. So obviously in the cancer center, what we focus on is the oncology genetics, which is becoming more important. And I would say we're learning more about it. I mean, just the understanding the human genome. My understanding is like the first human genome project to map the human genome took decades and billions of dollars. And now we can do an individual's entire genome in a couple of weeks for a few $1,000s.
It has advanced rapidly. And yes, we are now at a point where we can do, genomic testing, at a much quicker rate, at a much more accessible capacity. Prices are coming down. And it really is becoming a true part of medicine in general, just kind of helping patients to not only get that diagnosis, but also to, kind of tailor, their needs based on this genetic result and what they could benefit from.
Mm-hmm. So let's talk about the genetics in cancer. So my understanding is about 10% of all cancers in the United States are in some way influenced by the genetics, the genes that we get from our mom and dad.
Yes. I would say 10% is probably kind of the average quote that you see. I always say that's always subject to change, especially as we learn more and more about hereditary cancer and, just kind of the risks that it poses.
Mm-hmm. So if someone doesn't have any known pathogenic mutation a mutation that we know causes cancer, then we would say that they're at average risk. And most of the recommendations about when do you get screened and how often you get screened, and even what do you do for treatment of some cancers, are the usual guidelines are all based on average risk. But if you are at increased risk for getting cancer because of a known genetic abnormality, mutation, then sometimes our recommendations for screening are different, and even our recommendations for treatment may be very different.
Absolutely. I think that is probably very well illustrated, especially in the breast cancer realm, where a lot of our genetic understanding, I think it's probably the strongest in that area. And knowing, what it truly means to have what is known as a BRCA1 or 2 mutation, and how that can influence the course of treatment. Because as you know, there are drugs now designed to target people with those specific mutations. And I think that more and more will eventually be developed along the way. But yes, hereditary cancer usually does involve really a lifetime commitment to that screening, and just being aware of your own body and the changes, and taking advantage of these growing numbers of opportunities that we have to help hopefully kind of stem the tide and improve outcomes.
So we're going to talk specifically about breast cancer. We're going to talk about colon cancer, pancreas cancer, and maybe a few other specific. But before we go into the specifics, maybe give us a little bit of a primer on genetics. How many genes do we have? What do we get them from mom and dad? And maybe just use a little bit of the terminology to explain what genetics is, and then we'll get into why we are concerned about it with in a cancer center.
Okay. So I think way back in the day, we thought that humans were going to be very complex creatures with at least 100,000 genes. It's probably closer to 20 to 25,000 now that we've mapped the entire thing. But we do get half of this genetic material from each of our parents. We have 2 copies of every gene in our body, and we get one from mom, one from dad. And the genes we get from each of our parents have the same impact. By and large, it usually does not matter which parent it's coming from. It can still have significant health consequences.
Okay. And some conditions can be dominant and some can be recessive. Explain what that means, a dominant versus recessive.
Sure. So in a dominant condition, that means that you have inherited a gene from one of your parents that contains a mutation. And remember that we have 2 copies of every gene. By just having that one mutation in that one of those 2 copies, that means that either you would have a condition or be at increased risk for certain health conditions, which is really where hereditary cancer falls most often. Recessive is when a person inherits mutations in both copies of those genes.
And you'd have to have both the gene from mom and the gene from dad before that would adversely affect you.
Yes.
Or affect you. I mean, whether it's some recessive traits are not really diseases. They're just the way how tall we are, what the color of our eyes are. Those also are genetically predetermined.
They are. And a lot of these traits, they're not what are known as monoallelic or caused by one gene. It's really an interplay of several different genes. But the hereditary cancer genetic landscape, we do know that most of these predispositions are dominant in nature. There are some that are recessive. Those tend to be earlier onset cancers, unfortunately, in childhood. They are not incredibly common, but certainly they do exist.
So that's good to know that it's dominant. So getting it from either mom or dad predisposes you to be at risk. You don't have to have gotten it from both.
Right.
So now that you have given us a little primer on genetics, let's talk about cancer genetics. So you're a genetic counselor in the cancer center. What is the most common situation in which a patient would come to you to be counseled first about whether to do genetic testing, and then how do you actually do the genetic testing, and then there's a second counseling session that happens when those results come back in about 2 weeks. But let's go through some of the scenarios by which a patient would be referred to you for genetic counseling to begin with.
Sure. Many of my patients are referred because they have been recently diagnosed with cancer. I probably would say the largest portion of my patients are breast cancer patients. And so I may be seeing them to discuss genetic testing, not only to understand their own risk, but also to potentially understand if other family members were at risk. But sometimes this genetic testing can also impact surgical decision management.
Which treatment they're going to have.
Absolutely.
Yeah.
Absolutely.
Yeah. So sometimes it's a bit of a rush because, talk about stress. The patient's just been diagnosed with cancer and then needs to have genetic testing because knowing the results of the test, if they have a BRCA gene, then the treatment might be different. So they can't even have their treatment plan determined until the genetic testing results come back.
Right. And, I think our breast surgeons do a fantastic job of really explaining that to the patient when they're meeting with them the first time. This is why we're sending you for genetic counseling. And maybe it's due to the family history. For breast cancer, any woman under the age of 50 should be offered the opportunity to speak to a genetic counselor. And often surgical decision making will be kind of reliant on those results too.
And so that brings up a key factor that in general, individuals who have a genetic mutation that predisposes them to cancer, you often see those cancers at a younger age. So not like at age 80 getting breast cancer. At age 80 usually isn't associated with genetic mutations, but getting cancer at age 35, much more likely to have factored into it a genetic mutation.
Yes. Younger the age diagnosis, probably the more concerned I am. That said, I will tell you, I've seen many patients that, have surprised me. They're 65 years old and we are just now finding out that, yes, they did have a genetic mutation this whole time. But yes, people with hereditary predispositions are certainly at higher risk to develop cancer at younger ages.
So cancer at a younger age, more likely to have a genetic mutation. Individuals who have lots of family members with cancer, more likely to have genetic mutation.
Yeah. When I'm looking at a family history, I'm paying attention to, the types of cancers that have been in the family previously. Obviously, if we see the same cancer happening over and over again, I'm certainly suspicious for something. When I'm seeing breast cancer patients, I'm also paying attention to other genetically related cancers. So this can include ovarian cancers, prostate cancers, pancreatic cancers, and to even some melanoma predisposition as well.
So a patient's just been diagnosed with breast cancer at age 50, referred to you. One of the things you do is take their pedigree. You ask them to go through all family members that they know of and whether or not they had cancer. It's useful to know what cancer they had, at what age they were diagnosed with the cancer, and to some extent, whether they're living or have died of their cancer, that can be useful information.
Oh, absolutely. If with breast cancer, I always asked, if it was unilateral or bilateral cancer, how many did they have a recurrence, even kind of, their treatment course, what that kind of looked like. It can give you kind of a better idea of, that particular situation.
So the first session, you go through the family history. And what would be other important questions you would ask before determining whether to do genetic testing?
Well, we would go through and kind of explain, what can genetic testing actually tell us? A lot of patients are like, well, is it going to tell me anything other than hereditary cancer predisposition? And the tests that I'm ordering are really targeted to look at those hereditary cancer genes. So most of the testing I'm ordering is not going to be looking for any other conditions.
Right. And you're not ordering the test to determine where their ancestors came from in Europe.
Yes, I do.
Am I Norwegian or Swedish?
I do say that, we are probably not going to find out a lot about ancestry, though I have to say in some of these reports, when they kind of describe the mutation that's there, they will sometimes cite what population it has been found in and the rate. So there is sometimes some insight there, especially there are a couple different BRCA1 and 2 mutations that are very common in the Ashkenazi Jewish population, which is another question I asked, just because we know that particular population has higher rates of hereditary cancer. And so I have had a couple patients who've been surprised to learn that, they weren't aware that they had that ancestry, but at some point along the line, someone in their family did.
Okay. And then there are some concerns, or at least they need to be aware of some consequences of having genetic testing done. So it used to be that you could get charged a higher rate for your health insurance if you got genetic testing done and you were found to have a genetic mutation. Back in the days of pre-existing illnesses, you could get charged more for your health insurance, a number of factors if you had certain diseases. That's no longer an issue.
Right.
But there is an issue with other insurances, correct?
Yes. So there was a law passed back in 2008 called the Genetic Information Non-Discrimination Act, or GINA, because that's a mouthful. But this law does have protections so that employers and health insurance providers cannot use or even ask for genetic testing results to be disclosed to them, hence preventing any discrimination in the employment or healthcare arena. That said, while GINA is a great law and it very much complements the ACA, it does not have protections for life, disability, or long-term care insurance policies that the patient may want to purchase after genetic testing is completed. Those companies are allowed to ask if you've had genetic testing, and that can be used as part of their decision-making process. So that is definitely a risk that I go over with many patients. Unfortunately, some insurance companies will use health history, such as cancer diagnosis, that may also impact their ability to get those policies.
So those insurances are life insurance, disability insurance, and long-term care insurance.
Yes.
So that if you have a genetic predisposition to cancer, theoretically you could have to pay higher rates, or they could deny you a policy.
They could, yes.
Okay.
Yes.
So when you meet with the patient, you talk about what you might learn and what the consequences are. And they probably have already been prepped a little bit by their surgeon about how a genetic test result might change their treatment. So
Yeah. So when I am talking to the patient, I am trying to kind of gauge, their understanding of what I'm saying, asking them a lot of questions, kind of using the teaching back method. What I just said, like, tell me in your own words how you interpret that. So I am trying to constantly gauge their understanding, because I'm not doing a very good job if they're kind of, looking at me like a deer in the headlights, which, oftentimes they are, because this is, maybe the second or third appointment they've had that day. And it can become very overwhelming, but also letting them acknowledge what their anxieties are about doing genetic testing. I talk to a lot of parents, especially, who say, I know I can't control this, but I feel incredibly guilty if you were to find something. And we do kind of talk about that. And I try to gauge, guilty so much that, maybe you wouldn't consider doing this, or guilty that you still want to, but, you kind of wish you had more control over what happened. And there are some people that are often fearful that, well, I already have this diagnosis and, you've talked to me about what genetic testing might find. Oftentimes mutations will come with more than one increased risk. I don't know if I want to know the other increased risks. And I think that that's a normal reaction, to be fearful of that sort of thing. But I do find that more and more people are wanting to sort of reclaim some of that power too. And they're like, well, it's better to know than to not. And a lot of parents will tell me, I really don't care per se if this helps me. I really want to do this for my children, my grandchildren, my family.
Yeah. So if someone with cancer is a parent, and if they do the testing and they don't have a genetic mutation, it can be a real relief that they know that their children couldn't have that mutation. At least they couldn't have got it from that parent.
Absolutely. And I have heard comments like that. Oh, it's from the other parent. I'm like, well, probably, but yes, so there's definitely relief. Most of the results we get back, since we don't think the most of cancer is hereditary, most people will be negative. And I do sense a lot of relief in that disclosure phone call.
But if it's positive, there's also ways in which knowing that can help benefit the children, because if you have a known genetic mutation, we start screening at an earlier age, and so it can lead to better outcomes by knowing it ahead of time.
Oh, absolutely. And I think that is probably the driving force for a lot of people, especially those who do have very strong family cancer histories. They sometimes call themselves, I feel like I'm a ticking time bomb, and that I'm just sitting here waiting for something to happen. And this has sort of given me the impetus or the reason to go take care of this.
So back to our example, a 50-year-old woman diagnosed with breast cancer and also has a family history. You have counseled her. Now she decides that she does want to proceed with testing. Do you order the same panel of genes for every patient, or do you tailor the testing for each patient depending on the cancer they have and the cancers that are in their family history?
Yeah, it really is tailored to that personal and family history of cancer. There are some panels with a pretty explicit purpose. Those for stat testing for breast cancer patients, so we get those results back quicker. Those are straightforward, but I really do kind of take into account what cancers are present in the family, and really tailoring the panel selection to that.
Okay. So now this patient has decided that she does want testing. How do you do the testing?
So the testing can be done in a couple different ways. Most commonly, it is done through a blood sample, which is just a draw from one of your veins. However, saliva testing is available, and there are some tests that are able actually to process cheek or buccal swabs as well, which is nice for the patients that they are a tough draw. Maybe they've gone through a lot of chemo, and it's just kind of one less needle they have to put in their arm. So I do like having options, and I tell patients, I wouldn't offer these options to you if I didn't have the same faith in every single one of them.
So the three options you mentioned are having their blood drawn, spitting into a tube, filling up how many ounces or how many cc's of saliva, because that could be a problem for some patients.
Yes.
Can't generate enough saliva.
Yes, and I actually have a little demo thing where I show them this is how much saliva we will need, and some people are like, well, it looks like we're doing blood today.
Okay. And then the third is to do a little scraping on the inside of the cheek.
Yes.
Okay. And then how long does it take to get the results back?
Usually test results are available within about 2 to 3 weeks. The stat testing the turnaround time can be as quick as anywhere from about 5 to 12 days.
Okay.
On average.
And the stat would be done on a woman who needs to have surgery for her breast cancer, and you're doing a more limited panel for the breast cancer genes in order to make the decision to move forward with treatment. And you might follow that up with a bigger panel that could take longer, but doesn't have the same consequences on her treatment.
Right. And so I try to kind of explain that timeline and what it looks like, so patients can have a reasonable expectation when they might hear from me.
So explain why or how a positive test result for BRCA might change the treatment.
So if someone does come back positive for a BRCA1 or BRCA2 mutation, these two genes are very well known for, increasing that lifetime breast cancer risk substantially. On average, women with a BRCA1 or 2 mutation will have about maybe 55 to 70% lifetime risk for breast cancer. So
clearly they have to have their cancer treated that they have now, but if they have the mutation, even if they get this cancer treated, they still are at risk.
Yes.
50 to 75% chance that they'll get another breast cancer in their lifetime.
Yeah, so the recurrence risk can be very high for hereditary cancer. And other things to consider, especially with BRCA1 and 2 mutations, is that there's also an ovarian cancer risk to talk about, which can be very significant, especially for BRCA1 patients. Prostate cancer risk, which I think a lot of people tend to overlook. A large proportion of my patients are female. So when we're talking about family testing, they're like, well, I need to get my daughters tested. I'm like, your son should be tested too. Pancreatic cancer is another one that we'll have to talk about, male breast cancer as well, and even melanoma, higher melanoma risk.
So back to our patient, the way that it might influence, if she does not have a genetic predisposition, a gene mutation that puts her at higher risk, then she and the doctor may feel more comfortable just treating the breast cancer she has and understanding that every woman has a risk for another breast cancer, but that for an average risk patient, it's pretty low. And generally, we recommend treating the breast cancer that you have and not for the purpose of reducing the risk of cancer, removing both your breasts. Whereas if they have a genetic mutation that puts them at super high risk of developing another breast cancer, then sometimes the patient and the physician come to the conclusion, yes, you only have breast cancer in one breast, but because of the high risk, we should remove both your breasts.
Yes, yes. And so that is definitely a conversation that many of my BRCA1 and 2 patients will have with their surgical oncologist to kind of talk about, this. And the oncologists are very good about, this is why I want to do this for you. They're very clear about what that recurrence risk is, the chances of this coming in another breast, just wanting to be, most thorough, because the last thing they want to do is see that patient go through another diagnosis.
But it's always the patient's decision.
Yes.
So it's informed consent. And sometimes I've had situations where the patient is quite young and is still planning on having children and wants to do nursing and might decide, well, at some point after I've had all the babies I want to have, maybe I'll have both breasts removed. But in the meantime, let's just take care of the breast cancer now and deal with removing both breasts at a later date. Same thing comes into play with ovaries and uterus.
Yes.
Where are you in terms of your childbearing and where, at what point in time might you consider what we call a risk reduction surgery to remove either breasts, ovary, uterus that don't have cancer, but to remove them in order to prevent cancer from happening.
Right. And I think a lot of patients, may initially feel like I have to make all of these decisions right now. And I'm usually pretty honest with them, like everybody's journey is going to look a little bit different. It depends on where you are in your life. Do you want children? Do you want to be able to breastfeed? All of the oncologists I work with, they're always very sensitive to that. They're like, what do you hope for after this? So, and how can we make that happen to the best of our ability?
Okay. You mentioned male breast cancer. It's not very common, but it's much more likely that a male with breast cancer would have a genetic mutation because it's not a common cancer in men.
Yes, there have been some studies that have put that percentage as high as 40% of men with male breast cancer may have a genetic mutation. The BRCA1 and 2 genes are by far the most commonly found, but we do know that many of the other breast cancer genes also will increase female and male breast cancer risk. Though usually male breast cancer, for the sheer fact that there's far less breast tissue, will remain much lower.
And you mentioned it already, but I'll ask you again. Besides breast cancer, individuals with the BRCA1 and BRCA2 mutations are at higher risk for which other types of cancer?
So they are also at risk. Females are at risk for ovarian cancer. Males are at increased risk to develop prostate cancer. Both men and women will have increased risk for pancreatic cancer, and then melanoma cancer risk as well.
Okay. Let's transition to talking about colorectal cancer. So that is another cancer that we know is often associated with genetic or familial predisposition. When you are talking to someone who's been diagnosed with colon cancer. So for example, today I met a gentleman 45 years old diagnosed with colon cancer. What are the questions you would ask related to the colon cancer and the family history?
Yeah, definitely asking about, the colon cancer, the age at diagnosis. I ask about colorectal polyp history as well. And I know that is not maybe something that we're all talking about at the dinner table, but just having an idea of, hey, yeah, my dad had multiple polyps removed at some point in his life, and asking about their own kind of screening history. history. But we also know that other gastrointestinal disorders like Crohn's disease, IBS, all of these things can also potentially increase that risk as well.
Okay. And talk a little bit about Lynch syndrome. What is Lynch syndrome, and what's its relationship to genetic testing?
So Lynch syndrome is probably the most common hereditary colorectal cancer syndrome. It was actually named for an oncologist who was in Omaha, of all places, which is where I did my training. But Lynch syndrome is really characterized by increased lifetime risk for colon cancer. The other big cancer risk increase is also for endometrial or uterine cancer as well. And so when I'm asking about those family histories, I am focusing on those two cancers. But Lynch syndrome truly is one of those predisposition syndromes that can infect multiple types of cancers, bladder cancers, kidney cancers, a lot of cancers of the genitourinary tract, the gastrointestinal tract. It really does become, it is a really significant cancer predisposition syndrome that, there's a lot of recommendations on getting, imaging and screening done earlier and more often.
So we use the phrase Lynch syndrome. With BRCA1 and BRCA2. Those are genes, genetic mutations. What are the genetic mutations associated with Lynch syndrome?
So Lynch syndrome actually consists of 5 different genes that are involved in what are known as mismatch repair proteins. So basically, these are genes that are, kind of working to fix this DNA. But the genes are known as MLH1, MSH2, MSH6, PMS2, and then another gene called EPCAM or EpCAM. Those particular genes are involved in Lynch syndrome. And so anytime I'm suspicious of that, obviously all 5 of those genes will be ordered. But a lot of things about Lynch syndrome, there is some tumor testing that can also be done that can be indicative of a possible Lynch syndrome cancer.
And by tumor testing, you mean an individual who's had cancer removed, that you can look at the tumor itself, and some aspects of the tumor cells can be indicative of Lynch syndrome.
Yes. So in Lynch syndrome, they will often detect something called mismatch repair deficiency. And so when that is present, we know that the vast majority of Lynch syndrome tumors are due to that. And so when that is noticed in a biopsy sample or, a surgical sample, often that is kind of the thing that gets someone into genetic counseling, in addition to any family history as well. But that mismatch repair deficiency is one of the hallmarks.
And so Henry Lynch was one of my teachers at Creighton. And when he started doing the work, it was really recognizing familial patterns. So it wasn't doing the genetic testing initially. It was recognizing these family histories in individuals with colorectal cancer.
Yeah, no, he and his, the people he worked with, they were fantastic in, noticing these patterns in families and being like, wow, these people are being diagnosed at very young ages. And it's not just colon cancer, it's, these other cancers as well. And so it really, Lynch syndrome is kind of, genetic counseling really kind of evolved from things like Lynch syndrome, where people were looking for patterns, explanations as to why this family has so much cancer. And one of my genetic counselors at UNMC also had a chance to work with Dr. Lynch, and just, what a phenomenal thing that he was able to achieve. And I know that we're trying to move away from naming syndromes after people. I think it will always be Lynch syndrome in my head. Honestly, I know what the scientific term is, but yeah, and I think that's really what it kind of boils down to, is people are very good at kind of picking up these patterns and then, realizing what role genetic testing can play and identifying the sources of those. So
as we've already described with the breast cancer situation, that knowing you have BRCA gene could influence the treatment for your breast cancer, and it also then prompts one to have the rest of the family evaluated, and that could change the screening guidelines. So let's do the same thing now with Lynch syndrome. Someone's been diagnosed with colon cancer at a young age, and they have genetic mutations that would indicate they have Lynch syndrome, how could that change their treatment?
So their treatment, it may impact their surgical management. Honestly, the colorectal surgeon will be very interested in those results, kind of thinking about, okay, what seems most appropriate given.
Really, it's how much of the colon
Yeah,
to remove.
yeah,
Yes. So just like in breast cancer, you might, instead of just doing a little lumpectomy, you might remove both breasts. In colon cancer, instead of just removing, 10 centimeters of the colon, you might remove the whole colon
right.
in someone who has
Yeah,
Lynch
and
syndrome.
yeah, and there are other colorectal cancer predisposition syndromes, ones that are actually more polyp based. Lynch syndrome tends to be more of a solid tumor, though it can present in polyps. But another gene that I'm thinking of is called the APC gene. We know mutations in that gene can result in people having hundreds, potentially thousands of polyps. So much so that it's just not feasible.
Not practical to remove
No.
all the polyps.
No.
So they may have a more extensive surgery.
Yes.
Yeah. And then obviously family members who have the genetic predisposition, we would start screening at an earlier age.
Yes, I think kind of the golden rule is thinking about the youngest person to be diagnosed with cancer in the family and going, 10 years before that. Most people are starting colonoscopies at 45. It is not unheard of for people to start screening as early as their 20s.
Mm-hmm. Yeah. So in the last decade, we've said individuals at average risk should be screened at 45. It was 50 for a long time, but now we're saying average risk, we screen at 45 because we're seeing so many more individuals with colon cancer at age 45, and we may lower it to 40.
Mm-hmm.
But those who do have the genetic mutation putting them at higher risk tend to have a younger age.
Mm-hmm.
But we're even seeing average risk people have it at a younger age now.
Yes.
Yeah, we're not sure whether it's diet related,
Mm-hmm.
all of the various food additives, all the chemicals all of us are exposed to, from plastics and PFAS and red dye and glyphosate and nitrates, and all of those things are probably contributing to the increased risk of cancer at younger ages.
Yes, absolutely. I get asked about that a lot. And I think, I say the same thing, and I'm like, it's probably a very complex answer to all of this. Honestly, I think that it deserves more investigation and resources. But yeah, I don't think there's one particular smoking gun.
Okay. I do want to touch on two other cancers for sure.
Okay.
Pancreas cancer and ovarian cancer. We've touched on both of them because there's they play into especially the BRCA, but maybe even Lynch to some extent.
Yes.
And endometrial as well.
Yes.
So what would you like to say that we haven't said already about ovarian cancer and the genetic predisposition?
Ovarian cancer is a cancer that just does not present with very obvious symptoms. And I think that makes a kind of a scary cancer to a lot of people. The same would probably be said for pancreatic. And I think since we don't have true screening for ovarian cancer, people with a family history of ovarian or breast cancer, prostate or pancreatic, I think it's certainly worth considering genetic testing to know if you could be at increased risk. By removing those ovaries and fallopian tubes, when the timing is right for the person, can result in a significant reduction for that cancer.
Besides the BRCA genes, are there other genetic mutations that are specifically associated with ovarian cancer?
Yes, there are a handful of genes that are associated with ovarian cancer. One of them I can think of is a gene called BRIP1. We also know that Lynch syndrome does have increased ovarian cancer risk as well, and that there is a lot of overlap between the breast and the ovarian cancer predisposition genes.
And then pancreas cancer.
Yes, pancreas cancer, again, a lot of overlap with breast cancer predisposition, which I think is surprising for a lot of people. But yeah, again, Lynch syndrome, pancreatic cancer, but we know of genes, other ones, especially one called CDKN2A, that also will significantly increase lifetime pancreatic cancer risk, to the point where, people even as young as 35 may start, participating in the limited pancreatic screening that is available now.
What is genomic testing, and how does that differ from genetic testing?
So genomic testing is going, obviously kind of far beyond genomic testing. It's genetic testing. By and large, in hereditary cancer, we're looking at specific genes, whereas genomic testing, we may be looking for kind of more subtle markers throughout the genome that can influence disease risk. It's
Another difference that, and correct me if I'm wrong. So
mhm.
when I explain to patient genetic testing, we talk about germ line, which really means germ is in germination, not germ is in bacteria,
Sure.
but it's the genes we get from mom and dad.
Yes.
So it's kind of our normal genes that we get, or the genes that we get from mom and dad that are kind of in all our cells. When we take a piece of tumor and look at all of the genes in the tumor, we refer to that as genomic testing. And you can actually have your cancers develop because there's mutations that causes the cancer to happen. So you might have normal BRCA genes from mom and dad, but your tumor might have developed a BRCA mutation.
Yes.
And that's only in the tumor cells.
Yes. And that's kind of a more complicated, complex concept to explain to people, that your tumor really has its own unique genetic profile. What I say is all cancer is genetic, but it's not hereditary. So cancer starts at the genetic level because there have been mutations that have caused the cellular machinery to kind of go rogue. Whereas hereditary cancer, that means a person was born with a mutation that's in every cell of their body.
Yeah, and predisposes them to develop the cancer. But then when they develop the cancer cells have their own genetics. And the reason we do the genomic testing of the cancer cells is it could tell us what treatment might kill those cancer cells. So we have what are called targeted therapies, where we have created drugs specifically to kill cancer cells that have a particular genomic makeup. So that's why that becomes very important in determining the treatment. So the patient may not have any genetic mutations that predispose them to cancer, but the cancer they develop sporadically might have mutations for which treatment could be more effective.
Yeah, definitely. And mostly it is the medical oncologists, who are ordering that testing, because that truly will, potentially change the treatments that they do offer. But it is kind of interesting to see the overlap, because, obviously people can have, perfectly, no mutations in their germline BRCA1 or 2. And again, we can see a mutation in BRCA1 or 2 in this tumor. Occasionally, you will see someone with a germline mutation, and then, of course, genomic mutation. Sometimes you can see really surprising things, honestly.
Yeah. And tumors can change over time.
Yes.
Like if you've cured a tumor, but then it recurs, it's not uncommon that the recurrent tumor recurs because it had mutated from the original tumor.
It's all that cancer is just trying to hold on and keep going. And so how it does that, it's,
The will to survive.
Yeah, pretty much.
Yeah. So we have about 15 minutes left. And I know there's going to be questions. So we have a live studio audience. You in the live studio audience group get to ask the first questions. If you are watching us live streaming right now, please put your question in the comments section of the software that you're using to watch us this evening. And Gary, you're up first.
Okay. Talking at in the very beginning, just how the technology has progressed in being able to do all this testing. What do you see in the foreseeable future? Do you think that that's still going to be something that is always going to be getting better and better? And do you think AI is something that's going to be helping out in trying to do some of this?
Oh, absolutely. I think AI is already taking, or becoming a valuable asset. There are, so many different genetic mutations, and each of the genetic testing companies performs their own classification of variants. And so things like AI are incredibly powerful, allowing us to look at data, far beyond any one person's capability to do so. So I do think that is one driving factor that will help us become better and better in time. Technology is improving. I truly think genetic testing will become just more a part of just mainstream medicine in general. I think one of the most encouraging things since I started working at the Deming Cancer Center is seeing more primary care physicians actually referring patients. It's not taking, that cancer diagnosis, for the patient to come in. It's like, hey, we're seeing a pattern here that is really concerning. So I am grateful that, I have so many providers who, see the value in it, and they at least want their patients to come see me. Doesn't mean they're necessarily going to test, but kind of knowing those risks and benefits. But I do think that genetic testing is just going to become more commonplace.
I want to highlight something you said that, we started off like, what's the most common referral? And somebody who's been diagnosed with cancer, and probably the second most common referral is somebody whose family has cancer, but they don't have cancer. Mm-hmm. And so that is an important part. And as you mentioned, primary care physicians taking care of a patient may just note their family history is ripe with cancer. They don't have cancer, but kind of wonder, should they be tested?
Yeah, absolutely. And so I'm grateful that is really picking up steam quite a bit, obviously helping to identify and also helping those primary care providers know, like, okay, what does my patient need to do to address this risk?
Okay, let's go to the next question.
I'm just kind of wondering what you say when you talk to somebody, maybe like I used to think, which is we're all genetics. Everything is genetics. We just don't understand it well enough, but it leads to kind of a fatalistic way of thinking. When your number's up, your number's up. You talk to other people and they'll tell you, no, it's not genetics so much. It's how you live. It's what you eat. It's what you drink. It's what you feel. It's what you think. Mm-hmm. That's what the majority of life is all about. Where do you come down on that? Is it a percentage thing, or?
I think when I'm talking kind of about, the pros and cons of genetic testing, and I mean, yes, of course, we all know that someday we will no longer be here, but, enjoying the quality of life up to that point, and, knowing if you are at increased risk, being able to do something about it. I do think that a lot of people, while no one wants to have a hereditary cancer predisposition, knowing they can do something about that, knowing they could potentially improve the lives of their family members too, I think that goes a long way. There will still be people that do not want to have genetic testing, and my job is not to tell them that they need it. Some people will opt out, and that is fine. I usually ask them, I'm like, well, if you are not interested, that is absolutely okay. My only request to you is that you at least make this known to your family members that it is available.
Yeah, I think it's all about risks and how can you mitigate the risk of getting cancer. So having the knowledge that you have a genetic mutation might lead to screening at an earlier age. We certainly right now think that a minority of cancers are predisposed by the genes we get from mom and dad, but we're probably going to learn that, everyone knows people who live in the hundreds who smoke and drank and did all the modifiable risk factors, and they still didn't get cancer. There's probably something about their genetics that is protective, and we don't know. Mm-hmm. But we do know some things, and the things that we know can influence what we do that can help promote better health. It might be enough to scare someone into stopping smoking, or it might influence when their doctor orders their first mammogram or colonoscopy. So it really, especially those things where the result gives you an actionable plan that can reduce your risk of dying of cancer.
Yeah, I think
yes,
you
Kevin.
mentioned that the BRCA gene may express itself as a prostate cancer. Are there any other genetic mutations that would also express themselves as a prostate cancer that you look for?
Oh, absolutely. And so a lot of the panels I order, they're not actually targeting genes associated with one particular type of cancer. They will include many. And so prostate cancer, because it is so incredibly common, is one of those cancers. But there are several genes associated with increased prostate cancer risk. One of those genes is a known risk gene called HOXB13 or HOXB13. There is one particular marker that has shown a several increased fold risk for men to develop prostate cancer. So that one, some of the other hereditary breast cancer genes like ATM, PALB2, the Lynch syndrome genes are starting to gain more evidence and traction to show that prostate cancer risk is increased. And I anticipate that, we are going to add more prostate cancer genes. I think that genetic testing, while wonderful, sometimes we haven't always had the most male participants. And so sometimes getting that data is harder, but I have seen a much bigger uptake, seeing more men in clinic every day with prostate cancer or a family history of it. So I think the message is getting out there, but there certainly are probably more genes to come. But yeah, many of them are included on these multi-cancer genetic panels.
Okay.
Maybe you kind of answered this, but when you're looking for something specific, with someone's breast cancer or the BRCA gene, do you look for other red flags out there, or they are just too many variables?
Yeah. So when I'm doing that family history, I'm asking about any and all cancers. Skin cancer, breast cancer, whatever type of cancer you're aware of. Or even, things that you're like, well, I wasn't sure if it was cancer, but they had, some polyps or something. Anything that's just kind of going to tick me, make me wonder, but yeah, no, I'm definitely wanting a full cancer history to the best of someone's knowledge. But, and I think going forward, as we become more cognizant of how important, this pattern recognition is that my hope is that we will start having these conversations with our families to say, hey, did you know that there is this family history of this? I can't tell you how many times I've had a patient come to see me and say, hey, I just got off the phone with my relative who is likely the family historian. I learned about cancer in my family I had no idea existed. And I think that, I think we're just going to keep getting better at that. Obviously, we go back far enough. We don't have those medical records anymore. So we're really relying on, just people's memories. But yeah, making an effort now to write these things down if we think of it. It may sound silly, but there are a lot of different kind of softwares and packages, or even just writing it down on a piece of paper. Hey, so-and-so had cancer. This is the type, this is the age, this is when they died.
Maybe to Ron's question, though, I think that if you're just looking for breast cancer and you want it back fast, you might do a limited panel.
Absolutely.
But that you often will do a broader panel, and the family history of other cancers might lead you to do a broader panel than if everybody only had breast cancer.
Right. Yeah. And there are definitely panels that, if we just have a family history of breast cancer, it makes complete sense to just really stick to those breast cancer genes. The likelihood of finding something in another gene is probably very, very low.
And so you talked about finding out all your family history. What do you tell someone who is adopted and has no idea and no ability to learn their family history?
I tell them that we're just going to focus on their personal history more, because that's going to, give us the best insight. Some people who have been adopted have made contact with relatives, but many have not. So really, when they're referred to me, it's usually because they have that diagnosis of cancer. Yeah.
And having a diagnosis of cancer and having no ability to find out your family history, does that usually lead to you offering them genetic testing? There is no way we are going to find these things out. And I think that, our genetics should not be a mystery. And does insurance usually cover it?
If insurance,
an individual.
Sure. And it may be possible that the person who is adopted, they may have a cancer diagnosis, and just features of that diagnosis allow insurance to pay for it. But to know that Insurance coverage, it's not the end all be all, that many genetic testing companies do offer patient assistance to people who are in need. They really don't want these financial barriers to be the reason you don't get
And then
tested.
it could be a fee of as low as maybe $200,
Mhm.
which, you know, is not insignificant.
No.
But in terms of what we often see for medical expenses, it's often within the budget of individuals, and the companies will often let you pay $10 a month, or if you can demonstrate the inability to pay, may actually do it for free.
Yes. Yeah. There are always extenuating circumstances, and it's a big part of what I talk about with patients. They're worried about how much is this going to cost, and so I tell them that, you know, at least with genetic testing, there are a lot of different avenues we can pursue. The genetic testing companies I order from do a really good job of taking the patient's situation into account and kind of meeting them where they're at to the best of their ability.
We have time for one more question. George?
Yeah, I know that genetic researchers have long been interested in identical twins. What about identical twins and cancer?
That is a good question. I can't say that I've looked at too many of those studies recently. But yes, obviously identical twins have been fascinating to researchers for a long time, because it truly does kind of give us a little more insight into how much control, or what role does genetics play? Because obviously genetics isn't the whole story. It's, nature versus nurture. I do think that, there probably have been some studies out there that, people with the same DNA, probably not surprising to see increased cancer incidence in those people. I couldn't cite anything specific. I don't know if you've read anything.
Yeah, no, I
Okay.
don't know. It's a logical question. There's probably papers out there that describe that. Some of the fascinating things are, identical twins separated at birth that grew up in different. So
Yes.
then trying to look into this nature versus nurture, how much, if they were raised totally different parts of the country, different socioeconomic, do they end up having similar personality traits and health outcomes, or is it modified more by nature? But fascinating, but I don't know the answer to the question.
Yeah, I don't know either. I think you obviously have to take into account the other known risk factors to develop cancer. So, alcohol, long-term tobacco use, diet, exercise, all of these things can also
Air
play a role.
quality, water
Yeah,
quality.
you name it.
So thanks for stumping us on the last question, George. We really appreciate that. If anyone watching this show knows someone who would benefit by watching it, they have a chance to do so, because this show will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel, and also at the Mercy Cancer Center website. I hope to join us again next week. Thanks, Elizabeth.
Thank you.